Welcome everyone to today's show. I'm excited about today's topic, which is biofilms and the role of biofilms in infection and quote-unquote die-off reactions and even in COVID-19. As usual, don't implement anything you learn from this call without first speaking to your primary care provider. All information is up to date at the date of the call. If you're watching this in the future, please brush up on the latest findings. So, biofilms, what are they? Why are they important? Biofilms are communities formed by bacteria that basically allow them to protect themselves from our immune system, from antibiotics, from attacks from the environment. So just like you and I don't want to be injured, our cells don't want to be injured, bacteria living on and within us don't want to be injured and don't want to be killed. So what you have to understand is there's two forms of living for bacteria. There's the planktonic form, which is, say, the free-floating form or the individual form, one bacteria by itself, right? A socially distanced bacteria walking or swimming all alone, right? Then the biofilm is the community of bacteria. And the biofilm is basically the gym or the home or the mall or the restaurant or whatever you want from a metaphor perspective, where the individual planktonic bacteria can congregate and become a community. And when they become a community, they build a biofilm to kind of niche out, right? So basically a biofilm is a slime layer produced by bacteria, say on your gut lining or in your gums in your mouth or in the lung epithelia or in your bladder, wherever you have a mucosal surface. And they basically create this slime layer, this igloo that they can hide under. And the part of the biofilm that is attached to your self tissue, those deepest layer of bacteria, they are actually metabolizing and eating your tissue. They're creating inflammation there, and they feed off the exudate or the tissue that they're eating and metabolizing. And so those deep cells are called persister cells, and then each layer where you get closer to the roof, say, are further from the center and are more vulnerable. So why does this matter in humanity and in health? Well, a couple of reasons. One, 80% of all infections, the research says, are suspected to include biofilms. Well, why does that matter? Well, because that impacts potentially how the course of the case goes. For example, if you have a urinary tract infection and you take the antibiotic Cipro, and Cipro knocks out the infection, so you no longer have symptoms. I'm cured, right? But then a month later, you have a UTI again. You have the same UTI symptoms. You take Cipro again, Cipro knocks out the infection. I'm cured. A month later, UTI, same infection, Cipro knocks it out. That repetitive cycle there, where you have the infection, the same antibiotic knocks it out, you have the infection, the same antibiotic knocks it out, that is classic presentation of a biofilm infection. And so essentially what's happening is you are not killing the infection. The antibiotic is just knocking down the biofilm enough to make it asymptomatic. Essentially what's happening is if you picture the biofilm as like an igloo that the bacteria produce, the antibiotic is knocking off shingles on the roof and maybe killing enough of your surface layer bacteria that symptoms go away. But because it's not reaching deep, and it cannot reach deep into the biofilm, and neither can our immune system without help, it's not reaching the persister cells. So once the antibiotic course is done, your 10-day course of Cipro is done, the persister cells wake up and they're swimming in a pool of the guts of their friends that were killed. Well, that's nutrition for them. So now they metabolize it and they grow out the biofilm again. And once it reaches that point of symptomatic, you have another UTI, so to speak, okay? Why doesn't the antibiotic work effectively? Well, antibiotics were created in the early 1900s, and at that time, all we knew about were planktonic bacteria. And antibiotics are awesome against planktonic bacteria. So if you have an infection, you take an antibiotic, you knock it out, and it never comes back, so to speak, well, then that was a planktonic infection. That antibiotic worked great, no worries, right? But if you have this repetitive on-off sequence, we know that there's biofilms involved, and the bacteria, or excuse me, the antibiotics don't penetrate to the persister cells. So research is showing that if you combine the antibiotic with what are called biofilm disruptors, now the biofilm disruptors are punching holes or drilling holes into that igloo, allowing the medication to get deeper in and impact those persister cells. You don't always need medication. You can do it with natural herbs and things as well. But you need the biofilm disruptors too, otherwise you're shooting it and it's kind of like it bounces off the roof. Okay, you'll disturb some shingles, you may hit some of the sentries on the roof that are on guard, but you're not really going to get deep to the persisters. Biofilms love medical implants. So biofilms are commonly found on hip replacements, knee replacements, catheters, pain pack, pain packs that are surgically placed, say, on your spine or in other areas. So medical implants are large, high targets for biofilms. This study shows us the 5 stages of development for biofilms, and this study is called Looking for Chinks in the Armor of Bacterial Biofilms from 2007. And basically there's 5 stages. You have the planktonic form, right? A few friends get together and they just attach to a surface. When they reach stage 2, that's irreversible attachment. So you can see it's not just a group of people hanging out. Now it's a group of people hanging out and they're starting their igloos. In the maturation stage, the biofilm, they've gone from, say, a small igloo to maybe a 2 or 3 story igloo. And then the maturation stage goes through stages 3 and 4. So the 2 to 3 story igloo becomes, say, a whole community or neighborhood. And then stage 5 is dispersion, where now there's so many that you have a planktonic shower, or you have, say, the next generation leaves to create their own community elsewhere in the body. So this also manifests not only as infection, but in the concept of what's called the Herxheimer reaction or die-off reactions, okay? So oftentimes I'll have patients come in and say, oh, I tried X solution for, I think I had a yeast infection. So I tried, diflucan, or I tried some herbal remedy for it, and I got way worse. I had die-off, right? And so I can't take that. And it's not necessarily the case that the person can't handle that medication or handle that herb. It may be that A, they didn't realize they had biofilms, and the strategies they were using created a planktonic shower, okay? So if a biofilm is there undisturbed, picture it as an ISIS cell in your town, right? ISIS could be present in your town, but if no one knows they're there, they're operating under the covers, right? Nobody knows until they fly a plane into your building or whatever they're going to do, right? So they're there, they're not being picked up by surveillance, they're not causing any issues. But if the local police get a tip that, hey, there's an ISIS cell here, they go knock on the door, they go rip the roof off the house, now there's an acute inflammatory event, right? ISIS is shooting, the police are shooting, everyone knows they're there now. So you could say that town is worse that day than it was yesterday, right? Just from a symptomatic standpoint. But really it's the same town, we just know there's bad guys there that we didn't know were there yesterday, right? So clinically, if you're working with a practitioner and you enter a phase that is dealing with infection, say, and it could be gut, it could be sinus, it could be lungs, it could be bladder, and you're quote unquote worse since starting, it may not be because you can't deal with a certain herb, or that you're worse. It may be that you're successfully pulling roofs off ISIS cells, okay? And so what needs to be determined is, do you need to push a little harder for a little longer, or do you need to tweak dosing down? Like individually, you need to figure out with your clinician what needs to be done. But a die-off reaction or a Herxheimer reaction doesn't always necessarily mean bad. It probably most of the time means there's biofilms there that no one knew about. Why don't they know about them? Well, we don't currently have testing methodologies that can show us, hey, there's biofilms here. We don't, immunologically, our immune system doesn't see them well. So it's not until we can rip a roof off and see, holy cow, there's 100,000 more bacteria here than we thought a minute ago. We need more reinforcements, and obviously there's going to be more inflammation transiently. With the testing we do have, you can kind of intuit biofilms. So say you had a stool test and the microbes tested, there's no like obvious pathogens there. But you look at the inflammatory markers in the gut and they're very high. Well, perhaps the inflammation is high because there's microbes there we can't see because they're under biofilms. Excuse me. So there's two ways to confirm that, say empirically, clinically. You take action with an anti-dysbiosis type approach, and if you wipe them out and you retest and there's still not high levels of pathogens on the test, but the inflammatory markers are lower, hey, they were there and we knocked them down. If you retest and now it looks like there's way more bugs on the test and you're saying, oh, it's worse, it's not necessarily worse, it's now we can see what was there, right? So we can see more, so it looks worse on paper, but we can see what's there now, so we can better dial in and attack to those specific species. Plus, if you see those, but the inflammation is lower at the same time, we're still positively impacting it. We can just see more. Does that make sense? Good. And so those are things to be wary of, or not wary, but aware of. Now, if we take biofilms and we layer on the current events of COVID with it, there's research suggesting that COVID biofilms could be at play in the mouth, okay? And since it's an upper respiratory infection, researchers have investigated whether mouth rinses could be effective in helping decrease viral load and risk of infection. So here's a study from the Journal of Clinical Medicine, came out recently, April, and it said, the oral cavity is considered a major portal of entry for infectious agents and is directly associated with the evolutionary process of SARS-CoV-2 in its inhalation of ambient particles in the air and expectorations. So basically, SARS, you know, the saying is that SARS is spread through coughs and air droplets, right? And so how are we inhaling those? Well, through the mouth and through the nose. So the mouth could be a major portal of entry. Some new generations of mouth rinses currently on the market have ingredients that could contribute to lower the SARS-CoV-2 viral load. And SARS-CoV-2 is what causes COVID, right? So if we have mouthwashes that can lower the SARS-CoV-2 load, that would decrease risk of COVID infection. So these authors were saying, you know, if we can figure out a product that combines the mouthwash that's effective against it plus antioxidants that's effective against COVID, then that would be a valuable adjunct to treatment to decrease viral load in the mouth and nasopharynx and prevent infection and spreading. So I thought that was pretty cool. If we go to another study, here's a medical hypothesis recently, and these authors were talking about periodontal pockets. So in your mouth, around the teeth, you have periodontal pockets, and in those pockets, periodontitis can develop, or inflammation, okay? And inflammation of the periodontal pocket is the area around the tooth, or the teeth supporting tissues. This is very prevalent in adults, okay? So if you have bad breath, that could be periodontitis. If you floss or brush your teeth and you bleed, that could be periodontitis. That could be gingivitis as well. So These authors say periodontal pockets are ideal environments for subgingival bacterial biofilms that interact with subgingival oral or supragingival oral cavity, so it interacts with the mouth as we know it up here. Also mucosal tissues of the pocket and the peripheral circulatory system. So anything going on in the periodontal pocket could impact the mouth as we know it, like up top, right? The mucosal tissues of the mouth in the pocket and the circulatory system peripherally, because you can enter the blood through the mouth, right? We've all heard about the connection between, say, gingivitis and heart disease, right? Because it enters the gums. Just like we hear about leaky gut, there's also leaky gums, right? And that's a way into the body. So leaky gums or periodontal pockets have also been shown to be a harbor for viruses. Herpes simplex viruses have been found in these pockets. So these authors hypothesize that, hey, a periodontal pocket could be a favorable niche for SARS-CoV-2 as well. And so it's not proven yet, but they lay out their argument for it. And one of the big arguments is that, I don't know how much you've been reading on this, but the ACE2 receptor is the main receptor in the research that the virus uses to enter our cells, okay? And these authors say the ACE2 receptor, besides being found on the lungs and the nasopharynx and the salivary glands, are also being found highly in the oral cavity and the oral epithelial cells. They've also found ACE2 expression in the gingival and periodontal ligament fibroblasts, so the cells that are making the ligaments holding our teeth in place. And then they also cite research that recently found a different infectious route by SARS-CoV-2, which is by using its spike protein to bind to white blood cells that are CD147 positive. What the heck is that? Well, this study shows a picture, okay? So this study is called, mouthful, Clinical, Molecular, and Epidemiologic Characterization of SARS-CoV-2 Virus in COVID-19, Comprehensive Literature Review, found in Diagnostic Microbiology and Infectious Disease. And on page 6 of the study is a great picture showing the SARS-CoV-2 virus, and you see these spike proteins, okay? Well, the spike proteins are how the virus enters our cells. So this spike protein would bind the ACE2 receptor of, say, an oral epithelial cell, enter that cell, and now we've got infection in our mouth, okay, with COVID. Now, the study we just looked at also said, look, there's also been finding that SARS-CoV-2 can bind a different receptor called CD147. So not so much important to everyone as much as just saying it can enter through the mouth and through the mouth mucosa, so oral and dental health matters. Periodontitis we don't want to have, gingivitis we don't want to have. If there are mouth rinses and antioxidants we can use to optimize our defense orally, that's great, because the likelihood of someone picking up SARS-CoV-2 and therefore expressing COVID would be through inhaling droplets, particles, kissing, etc. So, and it ties into the biofilm piece, because this study suggests that oral biofilms can harvest viruses, and that would be a reservoir for SARS-CoV-2. So biofilms aren't just limited to bacteria. Viruses can be found in them. Fungal or yeast species can produce biofilms. It's across species. It's not bacteria specific necessarily. So I hope this opens your eyes up to help you understand maybe course of illnesses that you've suffered from, maybe repetitive infections that always come back even though antibiotics work, or maybe if you've had a die-off reaction in the past, maybe that helps put that in context for you some more. So if you want more information on this, check out my YouTube channel. I have a video on biofilms that I did. If you search biofilms cause chronic sinus, you'll find it. Also in my book, I discuss the immune system and how biofilms can be involved as well, called The Autoimmune Answer, on Amazon.